have a ways to go still. Yeah, if you guys have, I'll get started just because at least two here, will be this very informal. I mean, I do have a PowerPoint presentation. Hopefully some of the information will, I will kind of just formally go through, but please, if you guys have things that you would like to learn about or just talk about, you're on the front lines, and so I love to kind of hear from you guys as well. And I also hope that a few more people will trickle their way in because, 10 people did RSVP. I know it's a tough time of the year, though. So again, we're going to be talking about ending the HIV epidemic, and specifically, we're going to have a focus on expanding PrEP access in communities of color. And again, my name is Sean Bland. I work at the O'Neill Institute. I'm a senior associate there. I actually got my JD at Georgetown in 2013. I practiced for a bit, and then came to O'Neill about 4 years ago, where I've been working on kind of HIV/AIDS initiatives. And so I work predominantly on kind of HIV treatment and prevention policy. I do a lot of project-based work where kind of the goal is to kind of assist policymakers and HIV community stakeholders to think about how we can improve the response to HIV in the U.S. So a lot of that is focused on expanding access to treatment, so thinking about how we can adapt and sustain the Ryan White HIV/AIDS program, for instance. So that's kind of one of our central programs for treatment access for people living with HIV. It's the largest federal program that's exclusively focused on kind of treatment for people living with HIV. So do a lot of work on that. I also do a lot of work around supporting the National HIV/AIDS strategy, supporting high-impact HIV prevention, so like through CDC programs and things like that. And then more recently, I've been doing a lot of work kind of at the intersection of HIV and criminal justice issues. So I've been doing a lot of work in DC with advocates here who are working on decriminalizing sex work, for instance, and also doing work nationally around HIV decriminalization. So we have a number of states that criminalize people living with HIV, generally when they don't disclose their HIV status to their partners, but they do it in a very discriminatory way that's not at all informed by science. So there's no risk of transmission even. So if someone's like spitting at like a police officer, for instance, and again, this is disproportionately used against communities of color and other kind of overly policed communities, including sex workers. But they have significant consequences. They contribute very much so to stigma when we're talking about how we can think about what role stigma is playing and its impact on HIV and HIV prevention. Those types of laws, those types of policies, do have a big impact. So it's kind of how we can think about changing those things. So disclosure, I always want to start with that, particularly if we're talking about PrEP. So the O'Neill Institute has received funding, and we still are currently receiving funding for two of our projects, so our Ryan White Policy Project and also a separate HIV prevention project. So that's funding we've received from Gilead Sciences. So it's important just to disclose that. Again, all the information and the research that we've done, we are, I think, a rigorous kind of research institution, so we're going to be presenting the policies, but just want to make sure that you guys know the disclosures. So we're going to talk about ending the HIV epidemic because that's, I think, a big focus in HIV right now. The president announced that they're going to try to end the HIV epidemic in the next 10 years. And so I think a lot of focus, a lot of resources are now on what does that look like? We've been doing work for the last several years on a variety of topics that I think fit within this kind of ending the epidemic. And a lot of the work that we do at O'Neill is thinking about how law is going to be important for solving health problems. And so we work not just on research projects, which is mostly what I do, but we do a lot of work on scholarship. So we publish in law reviews, public health journals, medical journals, just to contribute new ideas within academia, particularly folks who are focused on health issues. So that's a large part of what we do. In addition, we do these kind of research projects, which really is kind of bridging research, so scholarship, to the real world. So trying to have real world impact. In addition to that, we also do a lot of capacity building. So we have our LLM programs. So we have two LLM programs, actually, one in global health law and one in global health law and international institutions. So that's a way of kind of training law students, so after you've gotten your JD, to kind of focus on and get the training that you need to launch your career in health law. So we do a lot of that, but we also do kind of just technical assistance with health ministries globally, but also with a variety of partners within the U.S., so whether they be at the CDC, the federal level, or state and local health departments, or working with kind of community stakeholders in HIV. So in terms of the work that we're doing specifically that's HIV related and that ties into kind of thinking about ending the epidemic, these are a number of reports that we released in the last year and a half. So we produce a lot of different materials. One example I'll just give you, and we have copies up here for those who just came in later at the end. You feel free to grab some. One kind of standard way in which we do our work is we develop issue briefs on topics. So this is an issue brief that we released in March of this year. It's focused on how to have more effective HIV prevention among Latinx, gay, and bi men. That's a population that is disproportionately impacted by HIV and where we've seen some of the greatest increases in new HIV infections. We haven't seen very much of a response to kind of policy and programmatic response to really target that population and to both understand their unique needs as well as to how we can best address them. And so we wanted to kind of take on this issue just to raise and spotlight it for folks. And the way in which we usually do our work is we engage with different stakeholders. We usually hold convenings where we get 20 to 30 folks together to talk about an issue, to learn more about it. So we got together for this meeting. We had about 30 leaders in HIV prevention, particularly focused within the Latinx community, particularly for Latinx gay and bi men. They came in 2008 to kind of talk about this issue. What's the current status of HIV and health access in the community? What are the barriers? What are innovative models or approaches that are being done at the community level or at the state level and that we need to maybe think about scaling up so that we can kind of change the trajectory of HIV in that population? And then based on that, we produced this report, which our kind of issue briefs are usually like 15 to 20 page reports, which kind of comprehensively look at an issue. They summarize the literature, and then it makes kind of recommendations. So we do a lot of things like this, and some of that is here. In addition to the kind of issue briefs that we do, we've learned that a lot of folks don't read long documents. And so we found other ways to kind of get our information out. So we've developed two other types of documents. One is kind of like a big ideas report, which is usually like a 4 to 6 page report that's very nicely designed, that kind of lays out our big recommendations. This is one that we did recently, came out August of this year, on how we can scale up PrEP in communities that have the highest needs. So particularly thinking about Latinx gay and bi men, Black gay and bi men, trans women, women of color, and other populations, so including people who use and inject drugs, and making some very key recommendations there. And then we also have just kind of a shorter kind of 1 to 2 pager that we do, is kind of an infographic that introduces topics for audiences who might not have any background in HIV. And so we released one recently. Well, this one's on HIV prevention, we released earlier this year, and then this past summer we released one on molecular HIV surveillance or molecular cluster detection, which is a new approach which I can tell you a little bit about, but it's actually a pillar of the Hiv epidemic strategy by the Trump administration. So it's received a lot of attention. It's raised a lot of concerns for folks in terms of how that information could be used or misused, particularly in terms of sharing HIV surveillance data with law enforcement, and could be potentially used in HIV criminal cases against people living with HIV. So we release a variety of these types of quick take, big ideas and issue briefs, and we've kind of just laid this out, how this kind of connects to the Hiv Epidemic initiative on issues of how we can diagnose all people living with HIV, on treatment, on prevention, and how we can best respond to the HIV epidemic, particularly new clusters of infections. So that's the types of work that we do. So that's just kind of an overview of O'Neill and kind of the work that we do and some of the materials that are laid out here. For today's presentation, I'm going to just quickly give an overview of HIV in the US. I'm going to talk a little bit about social determinants of health. So when we think about the disparities that we're seeing for HIV, particularly in communities of color, among gay and bi men, among trans folks and other vulnerable populations, we're not seeing those disparities for biological reasons. That's not the reason those disparities exist. And even when you think about kind of individual behaviors, we don't see from all the kind of epidemiological studies that have been done significant, greater amounts of risk behavior, say in Black gay and bi men compared to, say, white gay and bi men or other folks. And yet we see significantly more infections in that population. The reasons for that have to do with social and structural issues. And so I'll talk a little bit about social determinants. I'll give just a little overview of the Indian HIV epidemic, and then I'm going to talk about a variety of issues and models for expanding PrEP access, particularly in communities of color. So just an overview, we have about 1.1 million people living with HIV in the US. About 1 in 7 of those, so 15%, are unaware that they're living with HIV. So that's an area that we need to continue to work on. We want to make sure that every person living with HIV is diagnosed and knows their status. That's key for them to get into treatment and to care, to get on antiretroviral therapy, so that they can have the best health outcomes for themselves. It also has a tremendous public health benefit as well. Once people know their status and they achieve viral suppression or they have an undetectable viral load, we know that undetectable equals untransmittable. So if you're undetectable, you can't transmit the HIV virus to your partner. So we would be able to stop HIV transmissions if we had every person living with HIV in care and virally suppressed. So that's key. It's also key for PrEP. So you can only get on PrEP if you know your status, you're negative. So you need to be tested to know that you're negative. And that is like your entry point for getting into PrEP as well. So testing is really at the key of kind of really thinking about how best to do both HIV treatment and prevention. Again, HIV is disproportionately impacted in the communities that I've just already mentioned. So we're going to need to have more HIV treatment and prevention efforts that are focused on these populations, as well as other populations that are often, I don't think, get enough attention, but like gay and bi men in our Native communities, as well as in our Asian Pacific Islander communities. Again, we don't have enough kind of discussions there, and again, those populations don't account for most HIV infections, but we see significant disparities, both in their access to PrEP and in HIV treatment as well. We see geographic disparities as well, particularly thinking about the South. So before some of you all came in, we were talking about geographic barriers. So just having providers in your community. There are many rural communities where there just aren't enough primary care providers. So when you're thinking about how do we scale up PrEP, if you don't have enough providers so that you can actually just see a provider when you need one to get on PrEP, you're not going to be able to get on. Similarly, there may be providers, but they might be an hour or 2 hours away from where you live. And if you don't have transportation or some other way to kind of access that provider, it's going to be a challenge. There are a host of other challenges in the South, ranging from Medicaid access. So we have 14 states that have not opted because it's the Supreme Court decided that Medicaid expansion under the Affordable Care Act would be a voluntary program. Many of the states in the South and also in the Midwest have not expanded Medicaid. That's going to have significant impacts on folks being able to have insurance to cover PrEP. And then just the infrastructure really in the South, in many parts of the South, particularly in rural areas, just isn't there. So in terms of your public health department capacity, really the capacity just to train folks so they know about PrEP, providers to know about PrEP, but also to make sure that we're making sure that all of our healthcare providers, our institutions, so that includes nurses, your frontline workers, all those folks are trained around cultural competency, around the impacts of transphobia, homophobia, and racism, all of that stuff. All of those issues come together, I think, in many parts of the country, but we definitely see it as a way in which it's kind of amplified the HIV epidemic in the South. And again, the South accounts for the majority of HIV infections, even though they account for only 38% of the U.S. population. Just in terms of just the breakdown, so we have about 70% of HIV infections are among gay and bi men, so 66% among gay and bi men, but then when you add in that 3% up there, which are gay and bi men who also inject drugs, that's about 70% of new infections. We see significant racial disparities. So among gay and bi men, the largest number of new infections are in Black gay and bi men. So you see that they have higher numbers of new HIV diagnoses than Latinx gay and bi men, and also white gay and bi men, even though, again, they account for a smaller percentage of the population. So again, Black gay and bi men count for about 1%, less than 1% of the U.S. population, but they are 1 in 4 new HIV diagnoses. In 2017, one, positive note is that we've seen a stabilization in terms of new HIV diagnoses in this population. But that comes after many, many years, actually over a decade, of just very steep increases in new HIV infections. And so even though we've stabilized, the numbers are so high. We're around almost 10,000 new infections a year in that population. And again, Latinx gay and bi men it's an area where we've been working a lot more. When we think about healthcare access, we think about immigration issues, a lot of things that are kind of intersecting and coming together to amplify the HIV epidemic in that population. And yet we haven't seen the same amount of focused attention on that on Latinx communities around HIV, particularly on Latinx gay and bi men. And their rates of diagnoses are, they're not as high as among Black gay and bi men, but they're approaching it. So 1 in 5 new HIV diagnoses are among Latinx gay and bi men, even though, again, that's a population that accounts for less than 1% of the U.S. population. And we've seen significant increases over the last few years, so almost a 20% increase in new infections between 2010 and 2016. Outside of gay and bi men, we have about a quarter of new infections that are among heterosexuals, and disproportionately Black women are impacted. So if you look at heterosexual Black men, heterosexual white women, heterosexual Latinx women, all of their infections combined are still less than among Black women. And so we need to obviously focus on women in particular, but particularly women of color and Black women specifically. And then 6% of infections are among people who use and inject drugs. We're seeing increases, particularly in the context of the opioid crisis, among people who use and inject drugs, increases in HIV infections. That's going to be an area that we're going to need to continue to focus on and have again, evidence-based strategies to respond. So that includes things like syringe services programs, but also innovative models like overdose prevention sites, which are access to kind of drug treatment for folks who need it, but also access to HIV and hepatitis treatment and prevention services, as well as a host of other social services. And that's an area that is currently being litigated. I can talk a little bit about that as well. So I just want to highlight, again, some of the other populations we think about race and the impact of HIV in communities of color. Asian Pacific Islanders are a population that they're not disproportionately impacted. They actually have, about 6% of the U.S. population are Asian, and yet they account for about 2% of HIV infections. So they're underrepresented in HIV infections. Yet we see some really disturbing trends that don't often get much attention. So we see even a higher percent of infections among Asians in the U.S. are among gay and bi men. So 90% of new HIV infections are among gay and bi men. So that's a higher percentage than that kind of 70 or so percent generally. So we see a high percentage, at least that's among men, who again account for most of the infections among Asians. And we're also seeing significant increases. So we've seen over a 6-year period, 42% increases in that population. So again, that's a higher percentage of increase than among Black and Latinx gay and bi men. So very high. And then when you think about Asian gay and bi men, 50% increase. So those are numbers that don't often get discussed. And again, how we have the discussion on the best way to address that, it may not be the same kind of national response that we might need for other populations, but there are obviously communities in, say, San Francisco and other parts of the country where thinking about ending the HIV epidemic is really going to have to center on what's going on in these populations as well. And similarly, in our Native communities, we see staggering increases as well. So nearly 40% increase in that population and 54% increase among American Indian, Native, Alaskan Native gay and bi men. And one of the, I think, unique things about this population, even though, again, the total numbers are very low, we look at these N numbers, it's about 250 folks in 2006 in terms of new HIV diagnoses, but you see a significantly higher percentage of diagnoses among people who use and inject drugs. So the response there is going to also need to be different and thinking about not just sexual transmission, but injection drug use. So trans folks, unfortunately, we don't have great data from the CDC on HIV among trans individuals, but we know that trans individuals, particularly Black and Latinx trans women, have really the highest rates of HIV diagnoses of any subpopulation in the U.S. The data that we do know suggests that almost 22% of trans women in the U.S. And in other high-income countries are living with HIV. That trans women are almost 50 times more likely to be living with HIV than the general population. And in DC, where we are, we know from a trans needs assessment from 2015 that trans women living with, that a third of trans women who were part of that study reported living with HIV, and that 50% of those living with HIV were trans women of color, so predominantly Black trans women. And we know, again, in terms of thinking about social determinants, we see high rates of interpersonal violence, including murder that's happening in our trans communities or against particularly trans women and trans women of color. We see high rates of unemployment due to discrimination. And obviously we see, particularly for trans women of color, we see the intersection of kind of racism, sexism, and transphobia, which really do exacerbate the challenges that they're facing. Again, we have seen some progress on HIV, and I want to definitely let you know about that. So we saw over a 5-year period significant declines in new HIV infections. So when I first started working in HIV, well over a decade ago, we were very much at 50,000 new infections a year. Now we are under 40,000 new infections. So that's a significant decrease, which, again, when we think about a lot of other health issues, we haven't seen that level of progress. So if you guys have been following just in terms of sexually transmitted infections, things like chlamydia, gonorrhea, and syphilis, we have had another year of increases. It's the 5th year in a row where we've had increases in all of those sexually transmitted diseases. But for HIV, we had some very significant progress, and now we're seeing a stabilization. And the reason for that, again, is because we're not really focusing on the populations that we need to focus on enough and making sure that they have access to prevention and treatment. But that's going to be an area where if we're thinking about ending the HIV epidemic, we need to do better. And so I'm going to talk mostly about PrEP today. over the next 30 minutes. But again, another key part of this is treatment. So among people who are living with HIV, how we can do better at increasing rates of viral suppression. So viral suppression rates are also too low. Only about 50% of people living with HIV are virally suppressed. And then there are also significant disparities, again, by race, by gender, by age, and also by geographic, so where you are in the country. Social determinants, just want to again highlight that again, because when we think about how we're going to end the HIV epidemic, a medical approach alone will not get us there. We know that medical care only really accounts for a small percentage of health outcomes. So when you compare it to things like social, environmental, or behavioral factors, healthcare really determines about 10 to 20% of your health. Everything else are the conditions in which you kind of are born, you live, you grow up, you work, and you age, which we kind of broadly think of as social determinants. And social determinants are challenging to kind of change, but they are influenced by policies, by our programs, and by systems. And so we need an approach that kind of thinks about the role of law, the role of policies to change the trajectory of HIV in the U.S. So these are kind of the social determinants that I think it's important to think about. So again, the behavioral, psychosocial factors, the health system, community context, social and economic conditions, and also neighborhood, like where you live, housing conditions, things like that, kind of the built environment. I won't go over all of these just because I want to get into the PrEP content, but again, when you think about psychosocial issues, you need to think about not only the behaviors that people are engaging in, but also their perception of risk. And I think, you could be engaging in behaviors that put you at high risk for HIV, but if you don't perceive yourself as being at risk, that's going to prevent you from, maybe getting on PrEP or for getting tested, which again, that's the kind of entry point either into treatment or possibly, being, hey, PrEP might be a good option for you. You definitely need to be thinking about mental health issues, so things like depression. We know that traumatic events, so things like childhood sexual abuse, have a big impact on HIV, so on HIV risk, and also on the ability to just kind of stay in care if you're living with HIV. So those are issues that all have to be thought about if we're thinking about having a comprehensive kind of health response to HIV. We need to think about the health system in a broad sense, so cost issues, access to insurance, provider availability that we mentioned earlier, making sure we have competent, linguistically competent, culturally competent providers, community context, so the social supports that people have, networks. So when we think about HIV and HIV transmission, a lot of focus doesn't really think about kind of the sexual and drug using networks that people are in, and often that will place you at a greater risk. So when we think about, particularly racial disparities, like a white person who may be in a sexual or network that just may have, just be at lower risk. And so your chances of coming in contact with HIV are just significantly less than if you are, say, a black gay and bi man who lives in, a certain part of DC, and your network are, say, other black gay and bi men or people who are using inject drugs. Thinking about those network factors, how to intervene there to make sure that we're providing appropriate prevention and treatment responses is going to be key. Obviously, thinking about stigma, so whether that be acceptance by your family, religious issues, or other forms of stigma and discrimination are also crucial. Let's see. Social, economic conditions, those are things like money. So having income, employment, having health insurance, having access to high quality sexual health education, so in schools, things like that, as well as just health literacy, being able to navigate a very complicated health system. Things like homelessness, you need to have housing. If you don't have housing, it's very hard to think that you're going to be able to prioritize HIV or other issues in your life. You need to know where you're going to be sleeping that night, as well as a host of other issues which I think are very much impacting the communities that are most impacted by HIV. So immigration issues in particular is something that we have a climate where we're seeing increased raids. We have rules out like the public charge rule that has a significant impact on people being able to access healthcare. So those things are also crucial. And then again, neighborhood and physical environment as well. The HIV epidemic is, again, announced by the Trump administration in the State of the Union this year. The goal is to reduce new HIV infections in the next 5 years by 75%, by 90% over a 10-year period. And it really revolves around 4 pillars. So again, diagnosing all people living with HIV as soon as possible, treating HIV infection rapidly and effectively to achieve sustained viral suppression over time, preventing new infections, so using evidence-based approaches that include things like PrEP, but also syringe services programs, and also responding as quickly as possible to new HIV outbreaks, and that includes what I mentioned around molecular HIV surveillance and cluster detection as being an approach that I think has a lot of potential to it, but again, raises a lot of concerns as well, particularly around privacy and criminalization. That plan really focuses on, in the first 5 years, specific jurisdictions identified by the CDC. So these jurisdictions account for the majority of new HIV infections in the U.S. And so they're going to be focusing on these counties across the U.S., so 48 counties, as well as D.C. and San Juan, and then also 7 states that have a significant burden of HIV in rural areas. So they're all outlined on this map. It's important, just the big thing to say is that they're going to be focusing on these jurisdictions. They're going to be working on those 4 pillars that I mentioned, scaling up things like treatment as prevention, or U equals U, that I mentioned before, PrEP, and also post-exposure prophylaxis called PEP, and getting those out there, and using syringe services programs, things like that. But they're not going to be contemplating any significant changes to the policy landscape. So based on this administration's plan, they see achieving that 90% reduction really based on the existing tools that we have in place, scaling those up in the right places, but not changing the health policy landscape. So that's not contemplating expanding Medicaid in the 14 states that currently don't have it. It's not contemplating changes in insurance coverage, where, again, we've seen significant increases in uninsurance in the U.S. Not worrying about that, and so it's debatable whether we can actually achieve that without changing all those social determinants that I mentioned, but this is what's kind of in that plan. Let's see. So there's some new money in the plan, which is great. I won't go through all of it, but it's almost $300 million in the first year. Speaking with and hearing from high-level officials from HHS and CDC, we should be expecting more money in the next 10 years after the first year. So numbers that should be, hopefully in the billions in the years to come, because we're going to need that in order to actually achieve the goals of this initiative. It's good news. It's welcome news, because we've seen HIV funding be flat funded for many years. So now we're seeing some increases, which is exciting. But at the same time, we're seeing an administration that is proposing cuts in other needed areas. So cuts to things like housing opportunities for people living with HIV, cuts to the Medicaid program, still trying to change the fundamental structure of the Medicaid program, as well as other kind of key programs that are going to be key to promoting sexual health and access to health care for populations. I just will quickly contrast this with what the community says it needs. I think a lot of folks were kind of surprised that the president mentioned ending the HIV epidemic in his State of the Union this year. People working on HIV had some inklings that announcement was coming. And because of that, they started their own plan. This is what we think we need to end the HIV epidemic, or what the community thinks it needs. There are some similarities, but there are also some differences. They set a goal 5 years earlier, so they said ending the HIV epidemic by 2025, so not waiting 10 years, getting it done in 5. Committing to ending the HIV epidemic, not a 90% reduction, but actually ending the epidemic, and really thinking about disparities, which again, how those disparities in communities of color and other populations. Focusing on access, but really thinking about equitable access, so framing things in terms of equity and social justice. Preventing new HIV transmissions, that's the same, but also, again, addressing social and structural factors, really keeping that front and center. Maintaining U.S. leadership in life-saving research, so not cutting funding to NIH, seeing the role that research plays in terms of supporting effective HIV treatment and prevention, and then also supporting the meaningful participation of people living with HIV, which is something that has been core to the HIV response since the beginning. And it's not only important to highlight, but it also, for this roadmap, but in terms of ending the epidemic by the Trump administration plans, how are they really engaging with community stakeholders, meaningfully having people living with HIV kind of directing, making the decisions about what this is going to actually look like. So there are a number of challenges, again, that are out there, again, in terms of the Affordable Care Act, which is the law of the land, but we have the Trump administration supporting the lawsuit to declare that unconstitutional. That could ultimately be decided by the Supreme Court. But there are, beyond that lawsuit, a lot of administrative actions to undermine coverage requirements and things like that are going to have big impacts on access to things like PrEP. As well as efforts to impose work requirements in the Medicaid program, which have been, decided by courts to not be consistent with the Medicaid program's goals. But again, courts are changing very quickly. We'll see where that kind of goes, but that's going to be an area that we're going to need to continue to keep a focus on. And I mentioned overdose prevention sites before. I think the overdose prevention site that's furthest along is in Philadelphia, Safe House. The U.S. Attorney's Office sued them earlier this year. We did get a decision last month that said that ruled in favor of Safe House, so against the government, which is trying to shut down Safe House, prevent it from going forward. The district court ruled that there was no violation of federal drug laws. Essentially, their argument was overdose prevention sites are akin to crack houses under federal drug laws. The courts decided against that. I mean, they're not for promotion of drug use, but rather for public health purposes. But again, that's just the first level at the district court. This is going to be appealed, and we'll see where this goes from now. But that's going to be, I think, an innovative tool that's going to be very helpful for thinking about, again, ending the HIV epidemic, but also it's an access point for things like PrEP. We have a conscience rule, which luckily over the last several weeks, a number of courts have ruled that cannot be enforced, but it would allow for, essentially, it would license discrimination by providers. So you can make decisions on, if I don't want to, not only think about it, I think we often focus on access to things like abortion or other sexual and reproductive health care services, but you could have providers saying, I don't want to prescribe PrEP to, a black, gay, or a bi man or some other population because they don't agree with their lifestyle. Those are ways in which these kind of policies could have a big impact on access to PrEP. But that is something that we're going to continue to keep our eye on. Lots of organizations have filed lawsuits, and again, we've had multiple courts now rule against the administration on it, but it's a policy issue that's really important. We've had rulemaking that's been proposed to weaken discrimination provisions within HHS, within kind of how HHS interprets the anti-discrimination provisions of the ACA. So we'll see where that kind of goes going forward. Even if these regulations change, we still have obviously the statutory language there, but having good regulations is really, really important as well. And then I mentioned public charge, which essentially is a way to expand kind of really the impacts that taking public benefits has on someone's immigration status. And traditionally, we've had public charge, kind of the concept of public charge for many, many years, decades. This administration is expanding it, so thinking about public charge not only in terms of people who are, say, on like cash assistance or on traditional welfare, but folks who might be receiving Medicaid benefits or public housing, food stamps, things like that. All of that could be taken into consideration on whether or not someone who's an immigrant in this country and they're trying to change their status to become, say, a long-term resident, if they've taken any of those benefits for themselves or, say, their children, that could have an impact. And even before this rule was formally announced, so it was just kind of leaked for a number of people were hearing about it, and they were already very concerned in a lot of immigrant communities. And I think it's already had a lot of chilling effects on folks wanting to come out and actually seek benefits, which are very instrumental for your ability to access healthcare, to access PrEP. If you don't have housing, if you don't have food benefits, you're not going to be able to access PrEP. So just in terms of PrEP, we're talking about pre-exposure prophylaxis. I'll have about 20 minutes where I'll talk about various policy issues and access issues around PrEP. It is a relatively new technology. It was approved in 2012 by the FDA. It involves taking a single pill that, when taken as prescribed, we know is highly effective. It's so about 99% effective at preventing sexual transmission of HIV. Again, the only form of there are two formulations of PrEP right now, Truvada and Descovy, that have been approved by the FDA. Descovy was just recently approved last month. But the only regimen that is approved in the U.S. is daily pill taking for PrEP. So taking a pill every day, which again we know is highly effective at preventing HIV. There also has been research that's been done that shows that on-demand dosing of PrEP, so taking it not every day, but taking it before and after sex, is also highly effective at preventing HIV infection, particularly among, again, the population that's been most studied for on-demand PrEP has been gay and bi men, so we don't have the same level of data for among women or trans folks, but among men who have sex with men. And kind of the standard kind of way in which people have taken that is kind of a 2-1-1 kind of provision where you take two pills somewhere between 2 to 24 hours before having sex. You take a pill 24 hours after having sex, and then another 24 hours after that you take another pill. And that's been shown to be very effective in terms of prevention. But again, that hasn't been approved by the FDA. Where are we in terms of PrEP? again, approved in 2012. It took some time to get like larger numbers of folks on PrEP. Now we have about 160,000 people who are currently taking PrEP. And that's a significant increase, and we want to keep going and building upon that and scaling up among more people. Again, right now, that number only represents about 15% of folks who actually have a PrEP indication. So CDC did research, and they said, hey, almost 1.2 million folks could benefit from PrEP. And so we want to be getting all the folks who could benefit from it on it. And you can see in terms of the estimates of who could benefit most, we see the most numbers of PrEP indications are among men who have sex with men. The largest number among men who have sex with men are among Black men who have sex with men, but we also see, again, hundreds of thousands of folks who are white or Latinx who could also benefit from PrEP, who are men who have sex with men. We see numbers of heterosexuals as well, so including Black women. So these are all populations that, again, we're nowhere near these numbers that we need to continue to work towards scaling up. And we've seen some successes. We've seen increases in PrEP use among men who have sex with men, particularly in urban areas, but again, still too low in general, and particularly among people of color, and then very, very low among trans individuals and women and other populations, which, again, this is to do a little bit with just how PrEP was rolled out. I think a lot of the focus was very much on kind of gay men, I think in the initial years, and now really making sure that people see PrEP as an option for them, even if they aren't a gay and bi man or a white gay and bi man. But also we still have issues of stigma, which are very much barriers for folks accessing. So we see slut shaming that's happened. That was very much, the concept of like the Truvada whore was very, very much used. It was a term that you heard a lot in the first years after PrEP was approved. That stigma still exists. It's, I think we're going to see stigma in different forms, but, when we think about it among women, among trans individuals, among other populations, keeping an eye on that and making sure that we develop programs that kind of really are, sex affirming, that are, sex positive, as opposed to shaming folks for taking care of their health. So these are, again, we see significant disparities by race for PrEP users. So again, the vast majority of the PrEP users from this data set, which is from 2016, were men, and disproportionately they were white men, particularly white men who have sex with men, and significantly lower rates among Black men who have sex with men, or Black men, Latinx men, and other men of other races, and then very, very low rates among women. I definitely just want to point out that, again, we have PrEP use among gay and bi men, which is lower among African Americans and Latinos than among whites. And even those numbers among Black and Latino individuals, those are lower than among gay and bi men of other races. So we have a lot to do in terms of, again, making sure people are not only aware of PrEP, but are actually able to access it, and making sure that we're addressing barriers like racism, homophobia, and stigma, as well as the other challenges that I kind of mentioned when we were talking about social determinants. So these are just, again, some of those factors laid out along a continuum. So we've thought about kind of HIV treatment and also prevention in terms of, from just knowing about it, having an awareness of it, to actually being able to access to healthcare, being able to get an actual prescription, and then ultimately being able to adhere and stay on it so that you can kind of benefit from it. And there are a variety of factors that impact PrEP uptake along each of these parts of the continuum. So again, from awareness to perception of risk to barriers like cost or concerns that you might have about side effects, as well as perceived PrEP stigma, and then thinking about interventions that are going to be helpful for enhancing PrEP uptake. So those could be media campaigns, community mobilization, thinking about alternative forms of PrEP. Descovy is a new form of PrEP that obviously will address some side effects. So side effects for PrEP are very minimal. The vast majority of them go away if you have them after a few weeks. The ones that have received the most attention have been around kind of kidney functioning or their impact on bone density, which only really affects there really is only a concern for a certain segment of the population. But we have these, again, new forms of PrEP like Descovy, which are easier on the kidneys, that have fewer side effects, which could be very impactful. And then when we think about accessing the care, again, making sure we have insurance systems in place that we can pay for things, we have transportation, we have people have access to primary care providers, and then we think about interventions that can impact all of that is having, free provision of PrEP, assistance programs to help with the costs, things like that, as well as making sure we have systems in place to help providers. So that could be enhanced referral networks or centralized provisions in communities as well. And when we think about providers, again, providers, we need to do a lot better in terms of educating them about PrEP, making sure they're aware, that they're willing to prescribe PrEP, that they talk to their patients about sex, because a lot of, unfortunately, doctors don't know how to do sexual histories. They're not really trained around those types of things in medical schools, and so they don't know how to screen folks for their eligibility for things like PrEP. And so we need to have tools in place to better educate and train providers. Having things like electronic tools to assess risk. So like before you go into your doctor, for instance, when I go to like Kaiser here, there are just tools where I can kind of answer those questions through their database. So that's not even something that a provider has to ask me about, but they get that information, and then they can use that information to say, hey, would PrEP be a good idea for you? Those are kind of approaches that could be very, very helpful, as well as automated systems and reminders, and also just ultimately offloading PrEP a little bit. PrEP is very, very safe. It's like in a lot of ways akin to like aspirin. So a lot of the ways you may not need to see a medical doctor for all the care that you need around PrEP. A lot of that work can be done more by nurses and other health providers as well. So just giving some promising developments. We have awareness campaigns that exist. Some of the ones that are featured here are New York Playsure program and PrEP for Love in Chicago. So this image right here is from Chicago, the PrEP for Love campaign, where they're showing affirming, sex positive messages. They're showing real people from the communities, which I think, again, makes folks be able to kind of see PrEP as being something that's an option for them. And so those types of campaigns are really great. Public health detailing, I mentioned before, it's a way in which New York City first started using their health department representatives to go to visit primary care and infectious disease providers to educate them about HIV prevention, including PrEP and PEP, and teaching them how to prescribe it, and other jurisdictions have adopted that. So that's a way to, again, PrEP, we're not going to be able to reach scale enough people who are just relying on really the traditional providers that have been prescribing PrEP, which are predominantly Ryan White funded clinics, kind of HIV providers. Those are really great clinics like Whitman Walker Health that have predominantly served the LGBT community. Those are great, and we need to continue to build capacity there, but we need to also build capacity among just your average primary care providers so that they know about PrEP and are able to and are willing to prescribe it and talk to their clients about it. We need PrEP navigation, so really ideally not just using medical providers, but people of the community, just community health workers who not raise awareness about PrEP, but also help people who want to get on PrEP to navigate, again, our very complicated health system, making sure they can overcome barriers with their insurance. Insurers are putting all sorts of barriers like prior authorizations up, navigating all of that stuff, making sure folks can access other assistance programs, help them pay for PrEP. And ideally, we want to have these PrEP navigators be reflective of the communities that they're serving. So we want to have young gay and bi men, gay men of color, trans women, Black women, other populations kind of leading PrEP navigation efforts. I think that's a way of kind of, again, building trust in communities. And we have research that has supported these types of approaches. So an NIH-funded study that showed that high PrEP uptake among Black, gay, and bi men when we use client-centered care coordination, and again, by health navigators who are from the communities that they represent. We have pharmacy models that are out there that I think are going to be hopefully the future. Pharmacy models, the one-step PrEP program in Seattle has been used at a community pharmacy there, where you can kind of just go in, get your PrEP enrollment counseling. It takes less than an hour, and you leave with medications that same visit. So again, reducing the barriers that it takes to get on PrEP. You don't have to go to a primary care doctor. We have legislation that came in California, which now will allow for 30 to 60 days of PrEP or PEP available from a pharmacy without any kind of prescription or without prior authorization. So you can, again, eliminate some of those barriers to getting on. We have telehealth models, which, again, are going to be really crucial for, again, building capacity, making sure that providers know how to prescribe, that they actually have the supports that they need to actually implement PrEP in their clinics. So we have telehealth services that will, again, allow for they can be different ways. Again, you can have training for providers to make sure that they have the training that they need, but you also can have interactions between the patient and a practitioner in real time over your phone, over your computer, whatever way makes the most sense, and that can that's a way to expand PrEP access. And so we have programs like in San Francisco, PrEP Tech, which allows for, again, telemedicine visits, but home delivery of PrEP as well, and also testing, because again, you have to be tested for HIV to get on PrEP, but then you also need to be tested quarterly for HIV, and then also every 6 months, and possibly more for other STDs. So that's part of kind of a comprehensive package around PrEP and for sexual health as well. Again, insurance barriers are very significant. The cost of PrEP is high, so if you didn't have insurance, you're going to be paying, $1,500 to $2,000 for it. So you do need insurance to be able to cover it, not just the medication, but again, all those wraparound services that I mentioned. The good thing is insurers are paying for it, but we're seeing, again, what I mentioned, prior authorizations. We're seeing the use of or requirements of mail order pharmacies for PrEP. So again, you can only get it through the mail order pharmacy. So if you want to get it some other form that's easier for you, or if you don't have you don't have a mailing address, or you're unstably housed, all those things that can be challenges for folks. Those are barriers that are being put in place by insurers, and that will have a big impact on people being able to get on PrEP. We have some developments around variety of financial programs that allow for PrEP coverage. So Gilead, which is the manufacturer of the only FDA-approved medication, so Truvada and Descovy, they offer a number of patient assistance programs to help cover the cost of the medication. Or if you're insured, it'll help you to cover deductibles, copays, or other forms of cost sharing. And it's pretty generous. It goes up to $7,200 a year. So the disadvantage of this program is it's focused on the medication, so it's not meant to cover out-of-pocket costs for things like clinical visits, for lab visits. So again, you need to get tested for HIV, you need to have laboratory tests done. It's not covering that, so that's a gap. But also we're seeing insurers put in new policies like copay accumulator programs, and these policies don't credit the amounts that are paid by Gilead or pharmaceutical companies towards a deductible for the insurance. So you can use these programs like the Gilead program, get your medication for 3 or 4 months, but once you've exhausted the $7,000, if you have it, you still have to face a deductible after that. That's going to be a barrier for folks being able to access medications. We also have state programs. So in Florida, they're offering free PrEP to all of its residents. They're doing that through their county health departments, which is great. We have other states that have their own patient assistance programs. I mentioned just a few here. This is compiled by NASTAD, which is the National Alliance of State and Territorial AIDS Directors, to just show what different assistance programs cover. So do they cover just the medication? Do they cover wraparound services? Do they have income requirements? Things like that. And so we need to see more jurisdictions adopting these things. These are, again, if your state that you maybe come from, obviously everyone's here is currently in DC, but if you're from a state and you don't see your state on here, how can we get your state on here? If you see your state on here, how can we make your program make the most sense for the communities that you come from? We have some great developments. This came out the summer of this year. The U.S. Prevention Services Task Force gave a grade A rating to PrEP, that's a great thing. That's an evidence-based review, which essentially it says, hey, there's good evidence base for PrEP. Providers should be prescribing it to folks. And from a policy point of view, the grade A rating has significant impacts on the cost of PrEP. So it essentially says that nearly all private insurance programs, as well as the ACA marketplace programs, have to cover PrEP without any cost sharing. And starting in 2021. So when you have that grade A, or if it were grade B rating, it would have the same effect. And so that is, in effect, it means eliminating financial barriers for folks being able to access PrEP. The recommendation also has implications for Medicaid expansion populations by eliminating cost sharing down to zero. Again, additional advocacy is going to be needed, and so this is, again, if you all are interested on PrEP access issues or HIV issues, making sure that in your communities people are acting on this. So again, it's not like a self-executing thing. It's like this needs to be implemented by different insurers, by different Medicaid programs, making sure that actually happens. It happens on time. And also, what exactly does it apply to? Is it applying just to the medication? Or is it applying to, again, all those wraparound services that I mentioned? So HIV testing, other STD testing, all the clinical laboratory visits that all cost money. So there still can be cost sharing there. That if that is the case, then you've eliminated some of the financial barriers, but there's still going to be barriers to folks being able to really have the full regimen around PrEP. And again, you have to be tested for HIV in order to be on PrEP, because it's not a full regimen that you'd use for treating HIV in a person living with HIV. And so if you were to be on PrEP and you were HIV positive, there's a possibility that there could be drug resistance, which is very that's very bad for one's health, and ultimately getting them on the right regimen. So we have some programs that have been proposed at the federal level to kind of fill in some of these gaps to make sure that we're requiring all public and private insurers to cover both the drug as well as all the required tests and follow-up visits without any copays. This was legislation that's introduced by Kamala Harris from California. It would also provide funds to states and territories and tribal communities to support PrEP access. And it would prohibit companies from discriminating against people who are on PrEP in receiving life insurance, disability insurance, or long-term care insurance. That's something that has received, I think, a lot of attention over the last year, where we're seeing these types of discriminatory policies in insurance. Again, this isn't health insurance, where that would be prohibited, but in other forms of insurance, which, again, it doesn't make any sense. It's very discriminatory. Like, these are folks, people who are getting on PrEP are actually taking steps to improve their health to make sure that they don't become HIV positive. And then also having just public education, because, again, just making sure that there's education and awareness around PrEP is also very key. I just mentioned some of the discrimination in PrEP use and insurance. That's something that, advocacy, I think, has changed policy, but again, that's on a insurance company by insurance company basis. And again, insurance companies differ by state as well. So you can have the same insurance, but in different states, they have kind of different policies. So that's going to be an area that is going to continue to receive attention and will need to be worked on. We also recently had FDA approval for PrEP for adolescents. That was in May of last year. So pretty much anyone over 75 pounds can be on PrEP. So 75 pounds is roughly what you would be at if you were 13 years old. So essentially, if you were 13, 14, 15, 16, a lot of adolescent folks who may be having sex or could benefit from PrEP, those folks are now going to be able to get on PrEP with an FDA indication. Again, there's still legal barriers, and some of you may have faced some of these barriers before, or know friends who have faced barriers around, particularly if you're under 18, being able to consent to PrEP in your own right without having your parents be involved, and to be able to do so also in a confidential manner. So being able to get on PrEP and be able to pay for it without having any information from your provider or from your insurer, say in an explanation of benefit that gets mailed to policyholders after you've received a health service, having any of that information sent home such that your parents could then find out that you're accessing PrEP. So we need to have more safeguards in place to kind of safeguard against confidentiality concerns that a lot of minors in particular might have. But again, also people who are over 18 who, under the Affordable Care Act can be on their parents' insurance until age 26. So those confidentiality issues are going to be crucial to address. And we've had legislation at the state level to kind of narrow some of these gaps, but we still, again, these laws exist state by state for the most part, and so would need more advocacy to make sure that we're addressing these concerns. I'll finally talk about just a grab bag of other issues that you may have been following or hearing about in the news. One is kind of a patent issue with respect to Truvada. So there was a congressional hearing in May of this year about Gilead's pricing of Truvada, and a big focus of that was around the federal government essentially having patent rights to Truvada. So the federal government invested money to kind of through NIH and through CDC to show that Truvada, pre-exposure prophylaxis with Truvada, is an effective HIV prevention strategy. Yet, and even though there is a patent that's out there in which CDC actually has rights to, the government has not filed any type of infringement lawsuit to enforce that patent. And while Gilead argues that the patent is invalid, the DOJ opened a review of that earlier this year, and then they also recently just filed suit to enforce that patent against Gilead. So that's going to be a developing story going forward. What impacts that has, again, that'll be on Truvada's PrEP. So what meaning that has for the kind of the newest form of PrEP, Descovy, is unclear, but that is going to be something that if you haven't heard about, you'll hear more about, I'm sure, going forward. Gilead has also, around that same time as that congressional hearing, they announced that they were going to be donating PrEP to the federal government. So donating PrEP for 200,000 uninsured folks, for that many folks every year for a 10-year period. So it would be amounting to 2.4 million free bottles of PrEP going to the CDC over a 10-year period. Again, that is something, again, take it for what it is. It came around the same time as all of this patent infringement and this kind of congressional investigation, but that's going to be a tool for increasing PrEP access for folks. Obviously, one of the concerns, or at least there's a question around This donation will be for Truvada or for Descovy, but obviously, I think there's obviously an interest particularly among Gilead, to get folks on Descovy. And again, some of that's for good public health reasons. There are some folks who would not be able to get on Truvada. But there's going to be a question about what's the right medication for folks to be on. Should they be on Truvada? Should they be on Descovy? Do we need to be getting everyone on a Descovy? Not knowing what that price point will be, it'll probably be at a higher price point. And we have Truvada going generic starting in September of next year. So we're going to have something that, again, we don't know what the cost of the generic version will be. It may not be as low as what we would like it to be, but it could be in many ways lower, and so that'll be a cheaper medication that will allow us to get more people on it, and we know that Truvada is very safe and effective. Thinking about all of these changes in the policy landscape, what's going to be the right kind of approach for us to be taking, working with, again, CDC around its guidance, with health departments, and also just thinking about this Gilead program and what that's going to mean for access. So I mentioned generic PrEP. That was announced earlier this year. So Gilead reached an agreement that will allow for a generic form of Truvada as PrEP starting in September of next year. Again, what that's going to mean for costs is still unclear, but that is having a generic option will allow for some competition. So it's good just to not have one player that's doing all the PrEP manufacturing. And again, I mentioned Descovy already. Lastly, I want to kind of just talk about another lawsuit or set of lawsuits that have been happening. I don't know if you guys have seen any of the ads for this on Facebook. I pretty much every time I sign on to Facebook, maybe because I do HIV work and they just know to have this out there for me, but I see these ads which are advertising kind of a class action products liability lawsuit against Gilead. So they're being sued over alleged harmful side effects of Truvada as PrEP, as well as appearing to delay the development of this Descovy version. So it's the kind of safer version of a tenofovir. So it's a similar compound. There's tenofovir in both Truvada and also Descovy, but it's a safer and a different form of it. And the allegations are that they delayed developing Descovy as a way to maximize profits. And so these lawsuits have been definitely advertised in social media. I've seen them a lot on Facebook. I'm sure that they're in a lot of other forums as well. There's a worry that the consumer advocacy kind of law firms that are behind these suits are really misrepresenting kind of the case, as well as the dangers and the risk around Truvada. And they really just don't have the breadth and the depth of knowledge that they need. And so the concern is that people are receiving this information and they're seeing essentially what they're taking away is Truvada or PrEP is dangerous. Don't get on that. Even though, again, we have all the evidence that says that it's both effective and highly safe. And so figuring out, again, how to respond to some of these things. We've had a number of HIV organizations kind of issue fact sheets and other information and are starting to do community education around these things. But there's a big concern that folks who could be benefiting from PrEP are not going to be getting on it because they're hearing messaging like this, which is, again, I think just it's reflecting something that really isn't the facts around kind of the safety of the medication, but rather just an opportunity for litigation. And so we'll see kind of what that means going forward. And I'd love to get some of your thoughts about if you've heard it or know anything about these kind of product liability lawsuits. So we've released a number of reports on PrEP access where we talked about making recommendations around just making sure we have goals for how many people should be on PrEP, making sure we're thinking about disparities, making sure we're thinking about getting on and staying on PrEP as easy as possible. So again, having things like pharmacy models, having things like telehealth models, involving other types of clinical providers other than doctors, because again, whether you may not be able to see a provider or they're just too busy, making sure we're utilizing nurses and things like that. So we can task shift and making sure that we're actually doing that in all the parts of the countries that need it the most. And also just making sure that we're supporting making PrEP as affordable as possible and helping people to navigate the health system. So that's all in our PrEP scale-up brief where we give more specific recommendations for it. And I'll lastly just mention one other report where we released, this is not like our report, we wrote it. I wrote it with my boss for the National Minority AIDS Council, NMAC. It's like a two-part report actually. One, just kind of a blueprint for biomedical HIV prevention. So it's not focused exclusively on PrEP, but also on things like treatment as prevention or U equals U, and post-exposure prophylaxis, but making recommendations for particular communities of color because when we think about, again, all these different populations, they have different needs, and so our recommendations are going to need to be population specific. And so when we think about trans folks of color, for instance, we need to be thinking about, again, making sure that we build broad capacity, because we just know within our clinical and in our non-clinical care systems, there's just not cultural competency to address the needs of trans folks, particularly trans folks of color. So we need to be educating, improving just the standards for our systems. Really, we need to be hiring trans folks. They are experts in their own lives, so they should be they should be health navigators, but not just health navigators. They should be nurses and doctors, and also the heads of clinics and at CDC and at health departments. They can be leading at best making decisions about the responses for their community. Making sure again that we have trans-specific data, which doesn't exist. So we need that across the board. And we know again that for the next census there won't be LGBTQ inclusive data, but also all those other data systems that I mentioned, surveillance systems, things like that, all need to have data on trans folks, so we know what the current epidemic looks like in those populations, so we can track it over time and make sure that we're making the right adjustments and improvements for that population. And that includes both trans women, but also trans men who have different needs, and we need to make sure that we're spotlighting that population as well, and addressing concerns around HIV medications and hormones. So, I mean, I think, what the interaction between those two things, that kind of interaction, that brings a lot of concern for folks. And so just making sure that we have research on the safety, that we're communicating that to the trans community. Really, when we're thinking about getting PrEP out to folks, that we don't just think about trans folks only in terms of their HIV risk, which is high, but think about their broader needs. And so if they have concerns about actually accessing trans-affirming, trans-competent care, making sure that we provide that. And then, hey, if you also want to consider PrEP as an option, but really responding to their needs. And so we know models whereby we've, we haven't just had like a PrEP program, but we've thought about comprehensive trans health programs, developing those, including PrEP in that, but not just making PrEP or pretending like PrEP is the only need for, any population, but particularly for trans folks who we know are experiencing, again, all the violence and so many other issues that do need to be addressed, and trauma. Recommendations for Black, gay, and bi men, thinking about countering medical mistrust, thinking about, really cultivating a diverse kind of scientific and clinical workforce that really is taking on a multidisciplinary approach. I mentioned that HPTN 073 study. That was really a groundbreaking study, because it was a study that was conceived by, led by, and implemented by Black, gay men researchers. And so having that and taking an approach that isn't just a biomedical approach, but really thinking about what role care coordination, peer navigation, all that stuff needs to be taken into account to have a comprehensive response to the needs of Black, gay men. And also just thinking about supporting support systems. So we know the Black family, so Black mothers, like engaging family members to be advocates for their young sons to take care of their sexual health and to access PrEP. For Latinx folks, we're going to need similar things, but also unique things. So we're going to need to make sure that we're providing not only culturally sensitive and responsive interventions, but also linguistically appropriate. So we need things to be translated, we need things in Spanish, we need to be things, interventions that are developed from the beginning, from within Latinx communities and in Spanish, or whatever language is most appropriate for that population. We're going to need we'll need approaches that don't just lump all Latinx folks together, because Puerto Ricans are different from Mexicans, are different from El Salvadorians, so they're going to be different issues, and so we're going to need to be sensitive to that and to find approaches that work. We're going to need to promote, again, leadership in these communities. So it was great when I mentioned that HPTN 073 study that was led by and conceived by Black researchers, Black gay men researchers, having similar things for the Latinx community, Latinx-led initiatives, interventions that are supporting those folks to kind of develop approaches that work for their communities. And then also, again, very much thinking about undocumented folks, because our health systems very much lead out folks who are undocumented, and finding approaches. And again, what those approaches are, I'd love to get some thoughts on for you guys. So keep in your mind. I'll ask you guys some more questions, and if you guys have questions on things that have worked or need to be supported. But there's a lot more that needs to be done there. For women of color, we need to have messages. When I showed you those images before from that PrEP for Love from Chicago, again, a lot of those images were actually they were like heterosexual couples. There's a couple with a trans woman. There were gay couples, but having more representations and kind of messaging and campaigns that focus on women, and particularly women of color, is key. There's actually a great PrEP for Her campaign here in DC. I don't know if you guys have been seeing them. There still are ads that are up on buses and subway, like the bus shelters and on the buses themselves, but very powerful, striking images of Black women. So a campaign for PrEP for particularly women in the district, which is really great. But also just thinking about all the entry points that women are going to need to kind of learn about PrEP. So through family and reproductive health clinics, through Planned Parenthood, places like that. So really, when we think about PrEP, we need to be bolstering our kind of infrastructure for delivering comprehensive sexual and reproductive health care. So we need to continue to support those organizations that are already doing that work and need to continue doing that work under, again, very dire situations under this current administration. But we also want to make sure that they are, once they're interacting with these populations, thinking about HIV issues, including PrEP. Just thinking about approaches that are going to be trauma-informed, that are going to be thinking about women's lives. So in terms of balancing the multiple roles that a lot of women play as spouses, as caregivers, as parents, and making sure we have approaches there. But then also recognizing, again, PrEP is not recommended for all women. There's only really a fraction of women. But at the same time, we have these criteria for assessing who has a PrEP indication. But those guidelines actually lead out a lot of women, and so maybe they're not working very effectively, and they don't really take into account social and structural issues. So all those like network factors that I mentioned, if you're in a network where you could be, at greater risk, taking that into account. And so, we and a lot of other folks have thought about proposing alternative models of risk assessment. So not doing your traditional behavioral risk assessment, but really, which again, have a lot of stigmas associated with them, because a lot of folks don't feel comfortable answering them because you're talking about drug use, you're talking about sexual behaviors, and a lot of providers, again, don't know how to do sexual histories, and so they're not feeling comfortable asking those questions. So moving away from behavioral approaches to assessment of, again, everything we know about demographics, about epidemiology, about networks, taking all of that into account. So that could be offering PrEP to all women, all trans women of color, all sexually active Black women, all women of a certain neighborhood, so that people at least know about it. Hey, would you like this as an option for you? I can, making sure that people know about it when they're seeing their providers, and consider it as being something that's relevant to them, regardless of what their individual behavior is or their own perception of their individual behavior. This is a controversial kind of assessment. I mean, people will always just be like, oh, why are you, giving it to all trans women? But right now, we're not reaching those folks to let them know about PrEP at all. So they just don't either know about it or are not thinking about it as an option for themselves. So it's a balance. And then also just having effective approaches for young people. And I mentioned some of these issues as well. So that was a lot of content. I spoke a lot. I hope do you guys maybe have like a few questions? We have a little bit of time, like 10 or 15 minutes, depending on when you need to leave. And obviously feel free to leave if you need to. But thank you all.
I know that it came late, but how much is it?
So without insurance, it's going to cost $1,600 to $2,000 a month. That's just for the medication itself. And as I mentioned, to get on PrEP, you need to be tested for HIV, and you need to be regularly tested for HIV because you don't want to be taking just PrEP if you're HIV positive. So you need to, obviously have medical visits that go along with that. You'll need laboratory tests so you can get those results back. All of that has costs associated with it, including also usually most people recommend, because people who are at risk for HIV are also at risk for other STDs, they recommend having regular STD screening, which also has some costs associated with it. So it adds up. Insurance covers the vast majority of those things. And so we know that all state Medicaid programs, so state insurance covers PrEP. The vast majority of private insurance covers it. But particularly in the case of private insurance, there are costs that are associated with insurance, premiums, but also all the cost sharing that exists. And so that's the need to have, again, the state kind of PrEP assistance programs that exist, or that kind of federal legislation that I mentioned, to make sure that there's no cost sharing, or if there is cost sharing, that stuff gets covered, because cost remains, again, I can't say it's the biggest barrier. I think there's so many things to focus on. Again, education, just awareness of PrEP, particularly in communities of color, among Black and Latinx gay men, among Black women, among trans folks, making sure that we educate folks is still very, very huge. And yeah, so there are lots of other things, obviously, to make sure that people feel fully supported. Obviously, they need transportation to get to their medical appointments. They need all these other kind of social issues to be addressed, but financial barriers still remain very much a cost. They're very much a barrier. Yeah.
I'm just wondering, young people who are at risk for HIV? As you're talking about like health education curriculums, and how has that been like PrEP, but also just general like other preventative measures, or just general comprehensive education about HIV and AIDS? How has that been integrated already, and how do you think, if it has even at all, and how ought it to be? Because I remember in my high school sex education classes, the public school I ended up transferring to actually didn't even have one, which is interesting. But I also went to an all-girls school for some time, and it was, and I don't really remember it, I was like 12, but
yes.
I don't think that there was any indication of, there was nothing of that sort, and a lot of my friends just had no idea like what pap smear was or how STDs worked.
Yep.
So how do you think that?
It's a challenge. Obviously, we still have abstinence-based education programs in many parts of the country where, they have health education, but it's not really talking about anything that's actually going to prevent HIV or other sexually transmitted infections. So that's going to be a big thing, making sure that are those curriculums that exist, that they're not just giving lip service and just saying abstinence only, but rather actually giving the real information that people need to actually take care of their sexual health. So, I just think about mine, which was largely abstinence-based. I think they said a little bit about HIVs and STDs are dangerous. They're out there, so don't have sex. Instead of doing that, making sure people know, well, one, have access to condoms, know how to use the condom, like see what a condom actually looks like. It's not a scary thing. Like you like mention it, but like people don't know how to use them. They don't know how to access them. They don't know where to go for their sexual health care. So whether that be STD testing at STD clinics, which exist, and there are safety net programs that exist throughout the country that provide, free or sliding scale services, and that can also, refer to PrEP. People don't know where those are. They don't learn about those types of things. I think ultimately what they do learn is that STDs are this just very scary thing, as opposed to thinking about sexual health as being one that's a naturally important thing for a lot of folks, and kind of just reframing just the importance of sexual health for folks and making it, again, in a positive light for people, I think is critical. But yeah, I mean, it's a long way to go. It really needs to happen as early as possible, and so I see it really being crucial in school-based settings. But again, all of that gets determined at kind of the state level usually, and obviously we have very conservative states, and even in, I think, a lot of liberal states, again, a lot of that stuff also gets determined at like county levels, and so it is a challenge. We work a lot with not only folks at CDC, their HIV and STD provision division, but also their kind of division of kind of adolescent health, which kind of oversees all of the school-based programs. So working with them to make sure that they are doing the appropriate kind of technical assistance with states to, again, make sure that the curriculum that they have in place are actually responsive to the needs of these populations. And that also include, again, HIV disproportionately impacts gay men. A lot of STDs, like syphilis, disproportionately influence gay, like talking about gay sex and gay sexuality and gender identity and trans folks. Like all of those things are going to be, I think, very important to actually have effective, sexual health education.
Yeah, because when you were talking about like the barriers for young people in, the consent if you're under 18, but also if you're still on your parents' plan, like how you go about accessing like care or treatment or anything. And I mean, so I'm not from a conservative. I'm from California. I'm from Los Angeles. And even still, like my parents were very open about everything. My mom was like, "You're going to an OBGYN." Like she was very forthcoming about everything. Yeah. But a lot of my friends, even in liberal paradise Los Angeles, like their parents wouldn't let them go on birth control. They were abstinence only types. So yeah. Have to like take them to Planned Parenthood or take them to, and they'd have to sneak around their parents. And in terms of that, I know it is kind of state by state. Yeah. But with regard to like, what do you think like the biggest barrier is to those kinds of like consent laws, or also just having young people who may have barriers like in insurance, how to get that care without having to, I don't know, out yourself maybe to your friends or family?
So, I mean, it's tricky. I think one of the biggest kind of focuses around the confidentiality piece has been just allowing for alternative ways of receiving, say, medical bills, so explanation of benefits. So those should be able to be available electronically to your own individual email or to an alternative like post office box that's under your name, or some other place that you find to be like a safe place for you to receive information. So I think that's going to be critical. obviously, there are, just based on the state law, sometimes where there's the possibility for the main policyholder to be billed. They sometimes just get required to receive an explanation of benefits directly to that policyholder. And so changing those laws can be important. Actually, that involves like a change to, I think, federal law in most cases. So like ERISA and stuff like that. So that it's a challenge. It is actually a challenge. And I know in places like California, like in San Francisco, they've had like I forget exactly what they call it, but there's kind of just like an emergency fund for like PrEP for adolescents. So, you can access that if you don't want to like use your parents' health insurance. So having pots of money like that are available just for folks to access PrEP. I mean, it kind of works akin to how sexual health clinics work, STD clinics, where you can go there for free. They don't care about what your insurance is. You can just access services. So having options like that is going to be, I think, critical. The consent laws are, again, those are state by state. We've seen a number of states like not California, Connecticut, Illinois have recently changed their laws. New Hampshire is moving forward. So I think there's been a lot more attention from HIV advocates and folks to make sure that we have good laws in place to like allow for access to PrEP. We need more of that. And obviously, there are just going to be some states where I think it's going to be a heavier lift to